Well, hello, I'd like to welcome everyone to today's webinar, Understanding the VA Mission Act, Possible Implications, presented by Dr. Tracey Smith. This webinar is part of the Advocacy webinar series, which is a collaboration between Division 18's Veterans Affairs section and the Association of VA Psychologist Leaders. I'm Tiffany Fennell, Chair of the VA Section of Division 18 and a psychologist at VA Puget Sound. Before we get started, I'd like to take a brief moment to mention that Division 18, Psychologists in Public Service, has been the home for VA psychologists and other public service psychologists in APA since 1946. And the Association of VA Psychologist Leaders, or AVAPL, is a professional organization outside of APA for psychologists in the VA. These two organizations have a long and rich history of advocating for VA psychologists and the veterans we serve. For more information about these organizations, please check out the websites pod for links to these organizations' websites. And one last note before I introduce Dr. Smith, all questions can be entered into the chat box below. Dr. Smith will answer questions along the way, and there will also be time reserved towards the end of the presentation for questions. And if you experience any technical hiccups, please alert me in the chat box, and I'll do my best to attend to you as quickly as possible. So now on to introducing our speaker. Dr. Tracey Smith began her VA career in 2006 in Madison, Wisconsin, where she created an evidence-based psychotherapy PTSD clinic. She became the chief of psychology and served as a VISN PTSD mentor. Then from 2010 to 2016, she served as the National Psychotherapy Coordinator in Mental Health Services in VA Central Office. In this role, she worked on policy planning and implementation of the 15 evidence-based psychotherapy training programs and worked on many national mental health initiatives. Since 2016, she's been the Associate Director for Improving Clinical Care at the South Central MIRIC, where she works with the mental health leadership in VISN 16 and 17 to identify challenges in providing VA mental health services, use implementation science to develop quality improvement projects to address those challenges, and then disseminate those practices that are determined to be successful. As past president of the Association of VA Psychologist Leaders, Dr. Smith has been involved with advocacy issues regarding VA and VA psychologists. I'll also add that earlier this year, she was awarded an APA Presidential Citation for her service, and she was also recognized with the VA Section's 2019 Lifetime Achievement Award a couple of weeks ago at APA. So it's my pleasure to present Dr. Smith.
Good afternoon, everyone. Thank you for joining the webinar today. Before I start, I want to just sort of say a disclaimer. What I'm doing in this slide set is talking about what's in the Mission Act and then talking about concerns that some people have. We don't know if all those concerns are going to be realized, but I'm trying to create kind of a balanced picture of what's actually in the Mission Act and then what are people's concerns. And again, I only have 27 slides, so we have plenty of time for questions, so just ask questions whenever you like. So the full name of the Mission Act is the John S. McCain III, Daniel K. Akaka, and Samuel R. Johnson VA Maintaining Internal Systems and Strengthening Integrated Outside Networks Act of 2018. So now you know why we call it the Mission Act. The Act itself is 89 pages long and it has 97 sections. The primary goals of the Mission Act were to consolidate VA's multiple community care programs and authorities, establish an asset and infrastructure review process, expand VA's family caregiver programs to pre-9/11 veterans, expand telehealth, and increase VA's internal capacity to care for veteran patients in VA medical facilities through improvements to various recruitment and retention programs. So I'll be talking about each of these. The Mission Act established a consolidated VA community care program referred to as Veterans Community Care Program, or VCCP. And access to community care is required if the VA does not offer the care or service the veteran requires, the VA is not able to furnish care within designated access standards, a veteran and the referring clinician agree that furnishing care in the community is in the best medical interest of the veteran, a given medical service line within a VA facility fails to meet certain VA access and quality standards, and eligible veterans can be authorized 3 visits per calendar year at participating walk-in or federally qualified healthcare clinics. Payments to VCCP providers are generally Medicare rates. There's a few places that have higher than Medicare rates. So that has been a concern in other outside care programs in VA because oftentimes providers aren't willing to accept Medicare rates in certain areas. The Act also contains a prompt payment provision mandating payment within 45 days of receipt of a paper claim or 30 days from a receipt of an electronic claim. Again, this was to address problems with the CHOICE program. The Act also creates what's called a Center for Innovation for Care and Payment. It's not clear if this is a Medicare or Medicaid analog, but the authorization will exist to carry out pilot programs and develop innovative approaches to payment systems and delivery system models. So some objections to VCCP is that independent reviews routinely predict that veterans' health care that is outsourced from the VA to the community increases rather than decreases costs. Further, to manage the care veterans receive in the private sector requires contracting out to a third-party administrator, adding even more costs. CBO, which is the Congressional Business Office, estimates that implementing the bill will cost $46.5 billion over 2019 to the 2023 period. AFGE and several VA professional groups are concerned that as more care goes to the community, there will be fewer funds to support VA's internal programs in the future. Congress just recently increased VA's budget to cover this cost in the near term, but it's not clear how long Congress will continue to increase VA's funding. So VA proposed new access standards. I'm sure many of you have heard about this because you had to do whatever it was, 6 or 7 mandatory Mission Act trainings. But the access standards will be based on average drive time and appointment wait times. For primary care and mental health and non-institutional extended care services, VA is proposing a 30-minute average drive time standard. And for specialty care, VA is proposing a 60-minute average drive time standard. Appointment wait time standards of 20 days for primary care, mental health care, and non-institutional extended care services, and 28 days for specialty care from the date of request with certain exceptions. So some objections to proposed standards, and again, just to reiterate my previous statement, these are things that some people think we don't know if this is going to happen, but a number of professional groups within and outside VA have objected to the proposed access standards and upcoming quality standards because they believe VA's new proposed regulations will compromise the integrity of VHA healthcare. Requiring VHA to meet new drive time and wait time standards, whereas VCCP providers are not required to meet those standards. Proposing quality standards for VCCP providers that do not equal standards for VHA providers, especially for mental health care. There's concerns that we are incentivizing VCCP over-treatment, often found with fee-for-service models, that we're diverting VHA staff who perform clinical duties that to positions that administrate VCCP care, and that we're failing to address that additional expenses for VCCP will be likely drawn from VHA's budget. The VA Mission Act strove to remedy an omission in the CHOICE program, its failure to monitor the quality of healthcare services received outside of VA. It directed the VA to set rigorous quality standards for VCCP. Comparative quality scores for the VA and VCCP are to be made available to veterans and their providers so that they can make informed care decisions. The data will also be used to establish and renew contracts for VCCP providers, designating underperforming VA clinics whose patients should be granted automatic VCCP vouchers, and determining whether the VA should broaden pilot models of delivering private sector care. So, objections to these quality standards. Right now, we're having to use substitute measures of quality. For many diagnoses, there are few to no published quality metrics, and tangential measures are often substituted instead. And I'm sure a lot of us know that it's easier to measure quantity than quality. There's also an objection that comparisons are to the wrong population. So if you contrast VA to non-VA healthcare, it's often invalid because veteran and civilian populations are too dissimilar. There's a lack of sufficient data. VA and VCCP care quality cannot be accurately compared because many VCCP providers do not report any data. Provider quality standards under the CHOICE Act were that providers only needed to be licensed and not have adjudicated complaints against their license. They were not required to have any specialized training in military culture or for treating PTSD or other mental health conditions. Quality standards are still to be worked out for the Mission Act. VA members are asking that VCCP providers be required to meet the same qualification and training standards that VA providers must have. The insurance company awarded the contract, however, wants VCCP providers to meet the same requirements as CHOICE providers. So it's easier for them to fill up their panels if the requirements are only that somebody needs to be licensed and they don't have adjudicated complaints. So some concerns about quality. Community clinicians as a group lack military and veteran cultural competence, special clinical competence, or the access to a sophisticated array of therapeutic resources pertinent to military service health vulnerabilities. So in mental health, this is particularly important with PTSD. Previous RAND and other studies revealed that when compared with VHA providers, psychotherapists in the community who treat PTSD are unlikely to have the skills necessary to deliver high-quality care. So that's just one example. Section 133 of the Mission Act aimed to correct the deficit. It instructed the VHA to establish competency standards for the community care network providers who deliver PTSD treatment. The VHA formed a work group to develop criteria that was supposed to be due out this spring. I think we're still waiting for that, which will be handed to Optum Public Sector Solutions, the entity contracted to eventually oversee the CCN. Another important part of the Mission Act is it created this Asset and Infrastructure Review Commission, sometimes called the AIR Commission. So the AIR Commission requires VA to establish a 9-member AIR Commission appointed by the President and consented to by the Senate. The Commission would be tasked with considering recommendations made by VA and submitting a report to the President on VHA facility modernization and realignment. The report would then be submitted to Congress, and absent a joint resolution of disapproval, the recommendation would become law. So one problem with this is you can't, once the commission submits their recommendations, you can't say, well, we agree with this, but we don't agree with that. You either have to wholesale reject it or wholesale take it. So it includes additional authorities to allow VA to take action as may be necessary to carry out any recommended VHA facility modernization or realignment, and to transfer or lease properties to historic preservation organizations. So objections to the AIR Commission. AIR is loosely modeled after the Department of Defense's Base Realignment and Closure, or BRAC, process, and yet it differs substantially from BRAC. If 3 military bases are consolidated into 2, then the Department of Defense saves many expenses of operating the 3rd base when all the service members are redistributed and absorbed by the 2 receiving bases. If 3 VA facilities are consolidated into 2, however, the veterans receiving care at the 3rd facility would not go to the other VAs. In nearly all cases, the other facilities are too far away. In a few densely populated areas where another VA is within a reasonable distance, there is likely no capacity or space to absorb the redistributed veterans. The veterans from the 3rd facility would likely have to receive VCCP regardless of their wishes. So again, this is a supposition. We don't know that that would happen, but that's, I think, a reasonable supposition. So in the Mission Act, the VA can hand over a facility's deed to any private entity, even for free, as long as the entity complies with environmental restoration requirements. There's no restriction on what's done with the property once it's environmentally cleared. So for example, the entity could turn right around and reopen the facility to provide private care for veterans paid for by the VA. And the bill explicitly ties Congress's hands. There can be no motions to reconsider or amendments, as I mentioned before. The administration may fill the commission with healthcare executives who have a huge stake and a conflict of interest in VA privatization. These commissioners make the final set of recommendation, and it takes only 5 members to pass recommendations. While 3 seats are reserved for recognized Veteran Service Organization members, even if they voted as a block, their votes will have little to no influence on the outcome. So now I'm going to switch gears and talk about the Caregivers program as part of the Mission Act. The Mission Act expands eligibility for VA's program of comprehensive assistance for family caregivers, or I don't know how to say this, PCAFC, under the Caregiver Support Program. This program is currently available to eligible veterans who incurred or aggravated a serious injury in the line of duty on or after September 11th. The expansion implemented by the Mission Act opened the program to eligible veterans who served pre-1975 and their caregivers. So this part of the Mission Act is really what got a lot of VSOs to sign on, even though there were other parts that they were concerned about. So what does the Mission Act do in terms of helping VA workforce recruitment and retention? The Mission Act supposedly gives VA greater ability to recruit and retain the best medical providers through greater access to an education debt reduction program. It increases the maximum amount of VA's education debt reduction program for physicians only from $120,000 to $200,000 over 5 years, not to exceed $40,000 in any calendar year. It authorizes the program to be used as a recruitment and retention tool for vet center employees serving in mental health positions. The VA will also pilot a scholarship program for 18 eligible veterans to receive medical training in return for serving in a VA hospital or clinic for 4 years. And it establishes peer specialists on a VA patient-aligned care teams, or PAC teams, in at least 15 VA medical centers by May 31st, 2019, and in at least 30 VA medical centers by May 31st, 2020, to promote integration of services for mental health, substance use disorder, and behavioral health in a primary care setting. Section 403 of the Mission Act would require VA to establish a pilot program to expand the number of medical residencies in healthcare facilities operated by the VA, the Department of Defense, Indian Health Services, or other entities. Under the proposed pilot programs, VA would be authorized to pay stipends and benefits to eligible medical residents at certain healthcare facilities. For certain locations, the VA would be required to reimburse those facilities for curriculum development, staff support, and costs related to the accreditation of the residency program. Congressional Business Office estimates that about 110 additional medical residents would join the program each year, and that each resident would take an average of 3 years to complete the program, and that the average annual cost for stipends and benefits would be $70,000 per participant. KBP asked physicians only, not psychologists or social workers, and yes, that's correct, it's only physicians. Section 507 of the Mission Act, yeah, I agree with you, unhappy face. Section 507 would require VA to establish a 2-year pilot program to increase the number of medical scribes or personal assistants to physicians employed at the department, meaning VA. Congressional Business Office estimates that VA would need to hire 40 medical scribes, 20 term employees, and 20 contractors in 10 medical centers. Congressional Business Office expects that the pilot would run from the end of fiscal year 2018 through the end of fiscal year 2020. And these are sometimes called physician extenders because they can help doctors can spend more time on medical care and less time typing stuff into the medical record. Section 402 of the Mission Act requires VA to establish a program to provide mobile deployment teams of medical personnel to provide health care at underserved VA facilities. The Congressional Business Office estimates that each team would include 3 healthcare providers and that the cost to employ the staff of each medical team would be about $500,000. Costs for transportation and room and board would be about $64,000 per team. And VA will start with 10 mobile deployment teams in 2019 and grow to 15 in 2020. Congressional Business Office estimates that implementing this section will cost $24 million over the 2019 to 2023 period. So now I'm going to cover telehealth and some miscellaneous parts of the Mission Act. The Mission Act states that a covered health professional may practice in any state, in any location in any state, regardless of where they or the patient are located, if they are using telemedicine to provide treatment to the veteran, and provided they have an active, current, full, and unrestricted license. So we sometimes call this anywhere to anywhere care. The Act would also increase the fees charged to veterans who obtain loans guaranteed by VA, and it will extend the current limitation on pension amounts that can be paid to certain veterans who receive benefits from Medicaid. Section 106 requires that the VA, would this include telephone calls? Thuy, I don't think it does include telephone calls. I think it's only for telehealth. Section 106 requires that VA conduct market area assessments on the healthcare services provided by the department, and every 4 years this section would also require VA to develop a strategic plan to meet the demand of healthcare provided by the department. So some of you may have been at our VA Psychologist Leadership Conference. We were pleased to hear Dr. Cameron Matthews say this to us, which is, it's the ethical responsibility of VA providers to inform veterans that it is in their best medical interest to get their treatment at VA when the quality of treatment from a community provider is either not known or at a level that is lower than that what the VA would offer. So we don't often hear that from folks higher up in VA. It was well received, and it's one of the concerns I know that many of us have. All right, that's it for my formal presentation, so I have lots of time for questions.
Thanks, Dr. Smith. It looks like some people might be asking questions in the chat box if you're coming in.
Okay. The Air Commission has not yet been established. There was a bill that's before Congress to try and move up the date. I believe it's supposed to start next year. I'd have to go back and look at my slides or the act. But either next year or, I forget what year, 2022 or 2023, but there is a bill right now trying to move that commission up. Trying to move that commission, the forming of that commission to as soon as possible. Mary Beth says, what recommendations do you have if we don't agree with the new rules? I mean, I think we have to continue to talk to our leaders about our concerns. I would talk to leadership in the Office of Mental Health Services and Suicide Prevention. I would talk to your congressmen and senators. I would, if you know people in different veteran service organizations, they also have some concerns. So I don't think it hurts for us to talk to people. You always have to be appropriate in terms of you can't be doing advocacy on VA time, dime, or place, but you are free to express your views outside of VA on your own time. So Shirley Glenn says, so it sounds like from your talk that right now local facilities will not be responsible for covering the cost of community referrals now. For how long, or did I misunderstand? The local facilities are responsible for covering the cost of community referrals. What I was trying to say, Shirley, was that Congress increased VA's budget to try to cover some of the costs that the Congressional Business Office estimates will accrue because of the Mission Act. You mentioned that community providers do not have any requirements to offer care in a timely standard that VA providers do. Are there timeliness standards for VHA community care works? There are some timeliness standards for example, putting in your bill, but it's difficult for VA to measure when the care actually occurs. So they may have standards for when the referral goes, or when the care actually gets referred out, but it's hard to know. It's hard for VA to know when the care was actually delivered, so it's not the same as timeliness requirements for VA. EEA asked, does anyone know if it was ever decided if specialty PTSD is considered to be 20 or 28 day it's the 20-day window because it's mental health care. Do community providers have to do clinical reminders or treatment plans? Heather, as far as I know, they do not have to do clinical reminders. I don't believe they have to do treatment plans, but I don't know that for sure. They won't have to do a treatment plan like we do in VA. Heather asks, how can I become a community provider? Just kidding, mostly. I would contact the I think currently it's Tri-West that is covering the contract for VA community providers. And after that, it's going to be Optum. But I bet if you typed into Google becoming a VA community provider, you could find out. How do they plan to measure quality of care to compare community providers with VA? Emily, as far as I know, there isn't a good plan in place right now. I don't think anybody knows how they're going to measure quality of care to compare community providers with VA. There aren't great mental health metrics, for example, to measure quality of care even within VA. So then asking community providers to do something similar is going to be a stretch. Wayne says treatment plans may be requested by authorizing official to determine if there is a medical need, but this may be a local decision and not policy. Thank you, Wayne. Emily asks, patient satisfaction. It could be that patient satisfaction is used as a proxy for quality, and there actually is some literature to suggest that quality and patient satisfaction are highly correlated, but that may be what they end up doing. The language of the mission alludes to the closure of VA facilities. Any idea how this might get determined? SAIL. It could be that it's SAIL EEA, but it's hard for us to know. If you go to the main VA website and look at the comparison, but there's some comparison data now. It's primarily for medical specialties, but when Dr. Shulkin was the secretary, they stood up that VA website. I'm sorry, I can't remember the name of it right now, that compares VA to care in the community. The problem is for us in mental health is there aren't really good measures that are available that are used outside of VA. So Heather says, I have a patient with antisocial personality and PTSD who wants to engage in accelerated resolution therapy, which has some tentative evidence support. He has not benefited from modified DBT. The PTSD clinic won't work with him. He was denied Mission Act. Is it correct that Mission Act is for treatments that we do not provide at VA? Heather, I don't think that that is correct, that Mission Act is for treatments that we don't provide at VA. I mean, basically, it is and it isn't. So for mental health care, he is being provided treatments for PTSD. I don't know that we have good treatments for antisocial personality disorder, but it's more the issue with the Mission Act. For example, if a female veteran needs maternity care, and that maternity care isn't available at VA, then it would be sent out to the community. But it's not that a particular treatment isn't offered. That veteran was offered mental health care, if that makes sense. I'm just waiting for the next question to pop up. I love how engaged you guys are. It's fantastic. Heather, I'm going to add a caveat to that answer I just gave you about is the Mission Act for treatments that we do not provide. If a clinician at the VA said, this is the one and only treatment that this veteran needs, then they could probably make a decent case that he needs to get care in the community. Yeah, Heather, I don't know the literature on accelerated resolution therapy, but I think it's pretty early, so I have to defer on your question. So Wayne said we had a request for stellate ganglion block for PTSD in the community. I was consulted and provided the information we have on the efficacy of that treatment. And that was used to determine to deny the request. Request through mission needs to be medically indicated and medically supported. Thanks, Wayne, that's helpful. So Brent says we made a case similar to that in Kansas City and have seen it approved. So again, it's likely that there's going to be differences in what gets approved between different VAs. Heather says that is always a concern I have had with choice admission. There are no definitive guidelines. Yes, it's hard to have definitive guidelines, especially when you're comparing VA to the community. And it takes a while to get enough evidence. So Sam Wan said, in the San Francisco Bay Area, we are seeing a lot of approvals for substance use residential treatment programs due to our wait times for VISN residential programs. These programs cost in the neighborhood of $20,000 a month. It will be interesting to see if our local budgets will really have been well funded by mission funding for this. I agree, Sam. I mean, this is has been mine and others' concern since the very beginning, is that care in the community is much more expensive, and because there is sort of the contingency is not good. I mean, the contingency is to provide more care, not just the care that is needed, because they get paid for each episode of care. Again, I'm just waiting for the next type question. So Joanna asked, are any requirements in the Mission Act for community providers to share information, progress note, treatment plans? My understanding is that they don't have to submit progress notes anymore to get paid, because that was a problem with the Choice Act. It was really causing delays in payment, so people quit providing care because it was taking so long for VA to provide them. I think one of the things the Innovation Center is supposed to do is create a shared kind of electronic record exchange so that providers in the community can share information with VA. But maybe somebody on the line has better information about that than I do. Is there anybody on the call that knows about that, what the community providers are required to share? So Wayne said, I think, again, it's up to the local facility to determine what they want to see. So Wayne said we had a request for all records from our ACOS to review a request for community request renewal. So in a renewal, maybe they can ask for more documentation. Brent Kenny said, my understanding is they are not required, as you said, to keep the payment process straightforward. That's my understanding, Brent. Maybe in renewal, if they are required to justify getting more care, then they can ask for more. Any other questions?
Tracey, this has clearly been a hot topic, lots of questions pouring through. I see Mary Beth's typing.
Mary Beth, I'm curious what you would suggest we do if we don't like the rules. Thank you, Mary Beth. Mary Beth says she's not allowed to say here what she would suggest. Yeah, since it's being recorded, that's probably wise. I'm retiring at the end of this year, so I feel quite brave to say the things that I'm saying.
Yeah, it will be important.
You're all very welcome. Mary Beth Shea says, vote, question mark, question mark. Yes, of course, voting would help. Collectively.
I agree with Charlotte. It'll be important to continue to talk about this.
I agree.
Well, if there aren't any other questions, I don't know if you have any other kind of final words, information to share with us, Tracey, before I bring this to a close with just some logistics.
No, I don't. Thank you very much for attending, and I hope this was useful information. It was quite interesting to read the whole act and then also try and read between the lines, because often the way those laws are written, like the Air Commission, it sounds like, oh, we're just creating things and it's going to make VA more efficient and we're going to close down facilities that aren't useful anymore. But it's written in such a vague manner that there's a lot of latitude in terms of what possibly could occur, even unintended consequences. All right, I think that's probably it.
Well, then I will bring us to a close. I want to thank everybody for being with us today. And yes, thanks so much for your engagement. And Dr. Smith, of course, thank you for helping to clarify this Mission Act or possible ramifications for sure. So for those of you who are interested in receiving 1 credit hour of CE credit, you may request this by completing the online evaluation. I will put the online eval link here in the chat field, so you can go to it straight away if you would like to, but be sure to complete it by end of day on this coming Friday, Friday, August 23rd. So the link is now in the chat box for you and also in the notes pod. And just also a reminder that CE is free for both Division 18 and AVAPL members, since this is co-sponsored. And CE is available to non-members. If you wish to receive it, you'll have to pay a $15 fee through our PayPal account, which you can find in the note pod as well. And also, I'll follow up with an email to everyone who registered, so just to remind you of these instructions. And before we go, I'll give a quick plug for the upcoming VA Section webinar titled Pursuing Board Certification as a Professional Psychologist, the Clinical Psychology Perspective. This will be presented by Dr. Ed Newhouse, and it will take place on Thursday, September 5th at 1 p.m. Eastern. An advertisement flyer for this webinar is available in the files pod for download. And for any follow-up questions, feel free to contact me. Thanks again, everyone.